Hello friends, today we will discuss another important topic for MRCPCH clinical examination. This is a very difficult topic, so you have to be very well prepared before examination. The topic is how to approach a patient with arthritis. The scenario could be like that: a patient 6 years old presented to your clinic with joint pain, and it could be multiple joint or it could be a single joint. How you approach? It starts with taking history. First, you have to inquire about how is the onset, progress, and duration. That is same for all history scenario. Is there any aggravating factor or any relieving factor, and any other systemic symptoms associated with it. For arthritis, first we have to ask how many joints are involved, what are the joints are involved, is there any swelling, any warmth, any stiffness, any restriction of movements are associated or not. Sometimes fever, rash, lymph nodes as well as hepatosplenomegaly also associated. So you have to take all these things as a part of negative history. Then you have to move on to the past history of similar illness. Is there anything present or not? Past surgical history, always you have to ask. Then, is the patient on any medication or not? If the patient is on any medication, always ask, how is the compliance and is there any complication? Suppose a patient is on steroids. You know steroids have a lot of side effects, starting from the realizations, weight gain, as well as hypertension, high blood sugar. So everything you have to inquire. Then, how is the compliance? Is the patient taking the medication regularly or not? And you need to ask about what are the consultants associated with. Suppose a patient with chronic pain, maybe this patient is receiving a lot of support in terms of consultant follow-up, rheumatology follow-up, occupational therapy, physiotherapy, etc. Then you have to ask briefly about the birth history, immunization history, allergy history, as well as the family history. In family history, you have to ask about history of similar illness in the family. Is there anyone unwell in the family? Anyone is having a problem with the joints? Anyone is having the problem with the hypermobility? Next, you need to ask about the social history. As I mentioned in my earlier videos, social history is extremely important. Start with the school. How is the school going on? Is there any loss of school days? Is there any history of bullying there or not? How the patient is coping up with the pain and everything, how these things affecting the family life and how the family life is going on. Then you need to inquire about the personal history. How is the sleep? Maybe because of the pain, sleep is also affected. How is the wee? How is the poo? And any history of travel. Examination starts with the PGAS examination. Mind it, it is a musculoskeletal station. So if it has been given in a short clinical station, always start with the PGALs. For PGALs, you have to ask 3 screening questions. Do you have any pain anywhere in the body? Do you have any problem going upstairs and downstairs? Do you have any problem with buttoning or unbuttoning? Then you have to do the inspections from the front, from the side, from the back, as well as you have to examine the gait, upper limb and lower limb. You should watch a video of how to do the PGAS examination beforehand. Then you have to do the proper joint examination of that involved joint. Okay, so the scheme of examination is look, feel, move and function. You can watch my musculoskeletal examination that I already published. Then you have to move on to the few other things like eye examination, any lymph node examination, hepatosplenomegaly, skin, as well as the fingers, because sometimes skin is involved. Maybe there are some rashes going on. The nails are involved in psoriatic arthritis, please mind it, and sometimes dactylitis also there. So you have to do all the examination systematically. After having the proper history as well as the schematic examination, the examiner will ask what are the differentials. So you have to bear in mind, you have to prioritize the highest possibility of the particular differentials to get the highest marks. So first differential could be juvenile idiopathic arthritis, it could be septic arthritis, it could be reactive arthritis, it could be due to some trauma, some orthopedic cause, some trauma or hypermobility. Other causes, it could be leukemia or any malignancy. Bear in mind, leukemia and neuroblastoma may present with joint pain, limping. That's the worst possibility, but we have to rule out. So always rate the limping pathway very with highest importance. Okay, then move on. Some rare causes as well. There could be some rheumatology causes like autoimmune causes like vasculitis, juvenile SLE, as well as vasculitis like Henox-Colling purpura, Kawasaki disease, and some other uncommon causes like rheumatic fever. So you have to, and the non-accidental injury, I forget to mention. So these are all the list of differentials, but depending on the history as well as the clinical examination, you have to prioritize this order. Juvenile idiopathic arthritis. By definition, it should be 6 weeks duration as well as it involve less than 16 years of age. Highest incidence noted less than 6 years. It is associated with pain which varies in intensity. It can involve any joints and morning stiffness is noted. So stiffness becomes evident after taking rest. We will discuss the classification in next section. According to ILAR, juvenile idiopathic arthritis grossly divided in two parts. One is oligoarticular, another variety is polyarticular. Oligoarticular when 4 or less joints are involved, and polyarticular are when 5 or more joints are involved. Subtypes of oligoarticular is rheumatic factor positive and rheumatic factor negative. It could be also associated with ANA positive. If the ANA is positive, then the eye involvement may be associated. In polyarticular section, there is also a subtype, rheumatic factor positive, rheumatic factor negative. Let's move on to the next variety, that is the systemic onset juvenile idiopathic arthritis, which is associated with fever, lymphadenopathy, as well as the hepatosplenomegaly. Other variety, it could be psoriatic arthritis. In psoriatic arthritis, small joints are involved associated with dactylitis as well as the nail. There are another variety is enthesitis. In enthesitis, HLA-B27 is associated. And some variety where the ANA is associated, eye involvement is always there. The investigations. First, we have to do the baseline investigations. Full blood count using is LFT, CRP, and ESR. Next, rheumatic factor, ANA, anti-CCP. We can also consider the X-ray or MRI if the joint is grossly involved, and we can also consider the HLA-B27. That depends on the presentation and the possibility. In case of monoarticular arthritis, if we are suspecting septic arthritis, maybe joint aspiration microscopic culture may be indicated. And to rule out the eye involvement, we have to do slit lamp examination by the ophthalmologist. How to manage a case of juvenile idiopathic arthritis? First of all, we have to give the pain relief medication. We have to consider good analgesics in terms of paracetamol, ibuprofen. Sometimes we can consider NSAIDs. Next, if the joint pain is not under control, if it is grossly dysmorphic or we have already discussed with the rheumatologist, then the DMRD can be considered, like methotrexate. The next mode of treatment is biologicals, like anti-TNF antibody, etanercept, etc. But you have to support the joint, so physiotherapy should be the ideal. How we can support by doing physiotherapy? We have to give the support to the joint by giving splint. We can consider gentle exercise, passive movement, and you need to support the joint very well. Then we have to call the occupational therapy as well as the physiotherapy to look after it. And to see the complication like eye involvement, maybe mydriatics and steroid drops are associated, can be given. Sometimes we inject steroid in the joints as well to reduce the inflammation there. What is the prognosis? If we treat the patient, if we do the diagnosis very early and treat the patient timely, the outcome is better. But if it remains untreated, then the risk of growth as well as the risk of damaging joints are there. One of the common presentation in emergency as well as outpatient with joint pain, that is reactive arthritis. Most of the time it started happening after 7 to 14 days of infection. Some are HLA associated pathogens like chlamydia, clostridia, shigella, salmonella, and some of them are non-HLA associated pathogens like streptococcus, staphylococcus, mycobacterium, and some other infections. Sometimes viruses as well as a fungal infection can also lead to this situation. One of the variety of reactive arthritis is Ritter's disease, which is associated with conjunctivitis, urethritis, and arthritis. But this triad is very uncommon in children. I hope this video was useful to you. Please let me know which uncommon and rare topic you want to discuss so that I can make all these videos for you. Please like, share and subscribe my channel. See you in next time.